The key thing I want to say is, what have I been doing since I went to CQC? The thing that needed settling in CQC was, why do we exist? What are we here to do? This issue about our purpose has been contested for, well, years, more in health than in social care, if I'm being brutally honest. But this has been contested territory. So let me just drill into this statement of our purpose. Our job in CQC is to make sure that health and care services provide people with safe, effective, compassionate and high-quality care. And we do this to encourage services to improve. What am I trying to land in this? Well, I'm trying to land a number of things. The people responsible for quality in care services are all those of you that provide it. That's what I'm trying to land. Those that commission it, I'll come back to this in a second, are also responsible for the quality of those services. But ultimately, and this is Robert Francis's key message, is providers are responsible for quality. The regulator is not responsible for quality. The regulator is responsible for holding up a mirror that says, is quality here? And we'll call it as we see it. It isn't our job then to put quality into services. We are not an improvement agency. The people that improve services that aren't at the standard they need to be are those people that provide services. So I want to settle that argument and nail it for good in relation to CQC's role and what we're there to do. It still remains contested territory. If you ask people in health who's responsible for quality, you get a lot of people, not as many as used to be because people are slightly more cautious these days, but you get a lot of people coming in to do this. The other thing, we're not an improvement agency. There's a lot of people said it was really good when in CSCI you used to tell us what we needed to do to put it right. Well, I think we can still say actually this isn't good enough and you need to improve it, but go down to Happy Valley Nursing Home down the road because they're doing this really well. So we can flag up where improvement is going to take place. But as many people in this room have said to me in previous incarnations of my job, you're not there to mark your own homework. So it's not our job to identify what needs to improve, tell you how to do it, and then go back and check whether it's done to the way that we said it. For no other reason than the word innovation has been used while I've been here. And the key issue is about don't expect the regulators to be the leading edge of innovation. Innovation doesn't come from regulation. Innovation comes from those of you that are doing new, interesting, different things. And actually, my personal view about this is innovation comes from providers, not from commissioners. If you look at the great innovations in social welfare over the past, well, my career, it's hospices, it's housing associations. They didn't come from anybody commissioning it. They didn't come from government. They didn't come from regulation. They came from people working out how to do this better. I think the hospice stuff was driven by the voice of people using services. It was by people saying, actually, this isn't good enough. We need to do this better. While I'm in that space, personalisation is not about personal budgets. It's actually about how you personalise domiciliary care, how you personalise residential care, etc., etc. And I think we need to be really careful not to conflate those. I could say a lot about role, I'll not do that. We will be asking 5 key questions. That doesn't mean regulations are gone, it just means we're not going to ask 28 regulations, 16 outcomes, 5 outcomes or anything else. There's 5 key questions for me. Are services safe? I haven't got time to go through what that means in domiciliary care. Are services effective? Are services caring? Do they listen to people? Do they treat me with dignity and compassion? But also, critically, if I want to make a complaint, do these services listen to me? Or do they say this is nothing to do with me? Do you listen to your staff? How many whistleblowers do you have? And if you have a whistleblower, what do you do to them? Do you listen to them and do you use that information in the way that you run your business? We'll ask how responsive services are to people's needs. My office is in Islington, as it happens, but a couple of boroughs over, it's Newham. And in Newham, they speak 142 different languages in the primary schools. And if you think one of the issues that we deal with, you deal with, is that people whose second language is English if they get dementia, what they can often do is forget their second language. So how you run a dementia service in Newham is going to be very different than somewhere like, at the risk of a dreadful stereotype, Northumberland, which is probably as homogeneous as Newham is diverse in this country. And I think there'll be a difference in how dementia services are run in Northumberland to how they're run in Newham. And that's about services being responsive to the needs of the community that they're to be. It doesn't just mean do you hit your 4-hour this or your 12-hour that or your 28-day something else. It actually means are you responding to the community that you're there to serve. And then fifthly, how well led are services? There's a number of people here, I guess, that are large corporate providers. There's a number of you that will be medium size, and a number of you will be quite small, and you'll run your own business and you'll do much of what needs to be done by an organisation yourself. But one of the questions that we're interested in is how well led is the organisation that you either work in or are responsible for? What is the culture of the organisation that you're responsible for? And how, if you're responsible for the organisation, how are the signals that you send about what's important around here, how are they translated to your workforce? And how do your workforce take those forward when they're actually delivering care and support to people, in your case, in their own homes? What's the signal that you send? Is the signal that you send is that financial balance is important? Or is the signal you send getting it right for the needs of the individuals that you're there to serve is the most important thing that we do? You'll know what signal you send. I don't, but what we're playing at here is what's the nature of the relationship between the leadership and governance of an organisation, and not only what gets done, but how it gets done. And those of you that are larger, there'll be much more of a corporate centre, and those issues will be more resonant. For those of you that are medium-sized, they'll probably be more immediate. And for those of you that are very small, it'll probably be a sequence of quite personal interactions. But nevertheless, it's one of the key issues. I could say a lot more about this. But interestingly, my chairman has just been over on a study tour to America and looking at some of the big successful hospitals in America. They've almost stopped measuring patient satisfaction. And the key metric they're measuring is employee engagement. The reason why? You don't get engaged employees, you don't get high quality service. It sounds blindingly obvious put like that. So one of our questions is, how engaged are your employees? How do you know how that impacts on the quality of frontline provision? Because there is a direct relationship between these two things. I could say a lot more about that. That's a new operating model. We haven't got time for that. What are some of the differences around adult social care? I just want to pick up on this one issue. One of the key issues and the difference between what we do in acute hospitals, there are similarities here for community health care and mental health services, is very often what we're doing in adult social care is looking at the whole of somebody's life, whether they're a young disabled adult or an older person, rather than looking at episodes of care. There's a lot more on there that I could say, but I'll not. I want to pick out on this particular audience that top right-hand box of some of the issues that we're looking at in terms of strengths and weaknesses. Colin and Bridget are involved in groups that are looking at this kind of stuff. But there is this issue about a lot of inspection to date has really been about combining observation as a way of actually assessing quality. I think it's very difficult to use observation when you're looking at care in people's own homes. I make the same argument with community health care, an awful lot of mental health care and an awful lot of primary medical services care, actually. So domiciliary care isn't alone in this. But that combination of the power of observation, which is great in a care home, is absolutely essential in a hospital, doesn't quite work in the provision of domiciliary care. And therefore we do need to think about how we secure the views of people using services. These are Andrea's top priorities. She's been out and about. She talks about these. I'll not go on those. We're talking about 10 changes in the document we published a couple of weeks ago. We will, for the reason I've just touched on, be much more systematic about the use of people's views and experiences, including complaints. The key issue about mid-staffs is that members of the public and patients have been complaining about mid-staff since 2002. Nobody listened to them. It wasn't until 2008 the Healthcare Commission went in and did that inspection. It wasn't until 2009, the very last day of the Healthcare Commission's existence, that report was published identifying what the key issues were. The key message for me from that is the one that Robert Francis has emphasised on time and time again, and this applies for adult social care. This isn't a healthcare only issue, is the importance of listening to people that use services about their views. And what I'm signalling through this is much more of our time will be spent listening to people's views about their experience of services. We will use many more experts by experience and specialist advisors in the way that we inspect. We will be clearer about taking action. Do you know we've got care homes that have not had a registered manager for over 2 years? I think that's a shame on my organisation as well as a shame on the organisations that have allowed that to happen. Do you know why this is important? Because the quality of leadership is important to the quality of care. And surprise, surprise, those services with registered managers have more of a chance of delivering high quality care than those without. It's actually a bit of a no-brainer as this one. I think there's a really important issue about what are the values and motives as well as the ability and experience of those of you that are registered. What are the values that people bring? We had, going back to the 90s, to some of the child care scandals in residential care, a big debate about value-based interviewing. And I think more and more of you are going to get into this space in terms of ensuring that we've got the right people with the right values doing these jobs. And we're very interested not only in doing that for ourselves, but also in doing that in terms of looking at that in terms of our work. Ratings are coming. I think the appetite in adult social care for ratings has been very high, and we are working hard on that. The point that was being made earlier, sorry, I couldn't see who was making a point from where I was sat about better data and better indicators is absolutely spot on. We can't keep saying we haven't got the data to actually drive quality. You can't keep saying you've not got the data to drive quality. We can't have this as a zero-sum game about data and actually improving the way that we actually take these debates forward. So we really do need collectively to do something about this. There will be new standards and guidance. There is a key issue, I think, in this financial environment about removing duplication of activity between what we do in regulation and what commissioners do. I don't think there's any place in the tight financial environment to have duplication. Absolutely clear on that. I've done the leadership and I've done the stuff about ratings. I'm not going to do that. They're in time. This is Andrea's mum. I decided I'd leave it in because Andrea's made great virtue of asking this question when she's been out and about is this good enough for my mum? And I think this is not about Andrea's mum. I think this is collectively our mums, and just asking ourselves this question about, is it good enough? I'm not going to do that. Developer ratings. All these slides you can have, Bridget, so they can go on a website somewhere, and if people want to pursue them, they can come through. What I've not touched on is we've got some additional responsibilities as a care bill, which doesn't quite speak to, I think, some of the issues that you've been discussing this morning, but nevertheless are important about post Southern Cross. CQC were asked to do a piece of work in relation to financial stability. Particularly of the large care groups. And this is largely an issue not about stability but about continuity of care. Care groups have come in and out of business since, the 1984 Homes Act, quite frankly. The issue isn't the people come in and out of business. The issue is about what happens to the continuity of care for people where that happens, particularly where, in the case of Southern Cross, you had a large group where in some parts of the North East they had 30% of all residential provision in some local authority areas. So the issue is, this wasn't about a small number of beds disappearing from a quantum. It was about potentially a significant impact on the quantum of beds available at a local level, which raised real issues around continuity of care. So we will take forward this responsibility. It will be in the care bill. I guess people have mentioned that this morning, and we'll take that forward. Next steps, I'll not touch on that because there's a better graphic here. This is basically what we're going to do. Between now and March, we'll be out and about speaking to a whole range of different people in adult social care about the approach that we're going to take. We'll then publish in March consultation on our approach. We're waiting for the new regulations from the Department of Health. We're dependent on those in terms of moving forward. From March through to May of next year, we'll do our Wave 1 pilots. We're not talking about development sites or any of that kind of stuff. We'll be doing this. These will be real. But we will be saying we're going to learn from how we do this and build in the experience from those Wave 1 into what we'll do then from July through to September onwards, which will be the Wave 2. And then from October of 14, that new approach will be fully implemented, and we'll be producing indicative ratings for those services that we begin to inspect from October onwards. And our commitment is that every adult social care service will be rated from March 2016. These are slightly different timescales for what we'll do on acute hospitals, mental health services, community health services. So we've got a staggered period through that, but this is the timeline for those of you who are working in adult social care. Okay, that's me. Thanks.